England Journal is shown here. The problem concerns a 51-year-old woman who presented to a primary care clinic with abdominal pain. On physical examination, her liver was enlarged. So she underwent imaging and we're asked what this is. And if we look at this thing, we can see huge accumulations of cystic entities. This is a construction of an MRI, a computerized construction. And we also see a ureter, and that limits the diagnostic possibilities down to autosomal dominant polycystic kidney disease. Some of these cystic lesions I don't think are inside the kidney. They could be in the pancreas. I don't think that we can see the liver in this particular image, but at any rate, it's autosomal dominant polycystic kidney disease. And next week we'll get more information. These other differential diagnoses really are not germane to this image, with perhaps the exception of tuberous sclerosis, which is an autosomal dominant disease that is characterized by these hamartomatous lesions. They're common in the face, but actually in the lung and other organs. And this disease involves mutations in one of two genes that are a part of the tuberous sclerosis complex. TSC2 causes the more severe disease. This is all part of mTOR pathway, you'll recall. And what's interesting about this problem is that the TSC2 gene lies next to the gene that is responsible for autosomal dominant kidney disease. And there are also some pseudogenes in this area, and this was a big dilemma over 20 years ago when the autosomal dominant polycystic kidney disease was cloned. At any rate, this is also a condition that involves the so-called two-hit hypothesis, which is also the case for polycystic kidney disease, where one has one normal allele and a second mutated allele, and presumably some other lesion has to occur through some environmental influence or whatever have you, so that the disease is then manifest. The first topic in the New England Journal this week involves stroke. And as a little background, we're concerned here with stroked areas that are irretrievable and areas that find themselves within a penumbra, where there is still some viable tissue, perhaps from collaterals, etc., which could be salvaged. And this issue is of particular relevance because we can identify lesions that are beyond repair and lesions that could possibly be salvaged in patients with stroke with modern imaging. Magnetic resonance imaging is shown in this paper, or also CT evaluations. And the issue here is, could thrombolysis help people with stroke even after 4.5 hours after the onset of stroke? The randomized controlled trials that have been published to date were limited to patients that showed up with stroke that was less than 4.5 hours old, based on clinical and also experimental animal data suggesting that stroke beyond this range would probably not benefit from the treatment. Now, since a lot of patients wake up with stroke, it's impossible to tell exactly when the stroke occurred because they were asleep. And these patients have generally, because the time frame can't be estimated, have not been included in randomized controlled trials looking at thrombolysis as a treatment for stroke. So in this particular study, these are stroke patients that had stroke older than 4.5 hours, or patients that woke up with stroke. And the primary endpoint here is the number of patients that end up with Rankin scale scores of between 0 and including 1. These patients are then able to care for themselves and have minimal, if any, residual. So there are 225 patients randomized in this study that met these criteria. Half received alteplase, and the other half received placebo. So this is a recombinant plasminogen activator. And what we see here is that a large number of these patients have atrial fibrillation, which was probably responsible for their stroke episode. And 2/3 in each group had some evidence of large vessel occlusion, and all of them underwent imaging with a result suggesting that they might benefit in terms of having a penumbra that could perhaps be salvaged by thrombolysis. And that was done. So here's more details on the selection of these patients and the interventions that the patients received, alteplase or placebo infusions. And the primary outcome was how many people can we move into a Rankin score of 0 or 1. And so here's the outcome, and here is 0 and 1, and as we can see here, we have 46 patients in 40 patients in this area and 31 patients in this area, and that's a statistical difference. And on that basis, the regulating committee overseeing this trial stopped the trial because the patients had a benefit from undergoing thrombolysis. Now, we should also consider the fact that symptomatic intracranial hemorrhage occurred in a greater number of patients, and 7 patients here and only 1 here. And by a simple sign test, that's not quite statistically significant, but it does imply that this treatment is not necessarily totally harmless, because intracranial hemorrhage, as we might expect, would be more common in individuals undergoing thrombolysis that have had a recent stroke. So if we discuss this paper, what we see here is a substantial extension of the number of patients that come in with acute stroke that could possibly benefit from thrombolysis, particularly the patients that wake up with stroke where it's not possible to determine when they develop stroke. And this paper, the results of this paper will greatly increase the number of patients that can be treated in this fashion. Now, units that care for these patients are going to have modern imaging available at beck and call for 24 hours a day, and probably for the most emergency rooms, this will involve CT, but perhaps radiological teams that are able to place patients into MRI scanners that have had stroke around the clock will also enjoy a resurgence. The next topic is Nipah virus. I had never heard of Nipah virus, but now I'm informed. This is a single-strand RNA virus that is relatively common in Malaysia and the Indian subcontinent. The reservoir seems to be pigs, although in the country in which this observation was performed, I don't think they allow pigs in the country, because this paper is from Bangladesh. And this study involves 14 years of investigating patients with Nipah virus. Now, Bangladesh has a population of 170 million people. So since the number of patients over 14 years that are reported in this study is 248, I wouldn't think that this is a major healthcare problem in Bangladesh. But when we look at the patients, we see there are case patients, and then there are secondary patients that were infected, presumably with contact with the case patients. And it seems to be primarily a problem of pneumonia, because cough and shortness of breath belong to the symptom complex in addition to other symptoms. And these patients were not included on the basis of polymerase chain reaction diagnosis. This study was based on showing that the affected patients had clinical symptoms and also had elevations of IgG titers against Nipah virus. And if we look at the contacts here, they were exposed. For the most part, the contacts are relatives or friends that have a relationship with the index patient. And contact with bodily fluids seems to be an important mediator of transmission of this viral disease. So as opposed to Zika virus and agents of this nature, this is not a mosquito-borne problem. This is a contact-separated problem. And if we look at the blue circles or the blue squares and the contacts that were involved with these individuals, everything that's in blue also had shortness of breath. And we can look at the serial intervals of numbers of cases and the risk of exposure to contacts, and each one of these transmission trees is illustrated here, and the number of secondary cases is also shown in this figure. And it seems that older people, advancing age is associated with increased risk of contacts becoming infected, and the observed and predicted number of the age-related effect is also shown here, and the hours of exposure play a role here, and percentage of infected individuals is plotted against hours of exposures is illustrated here. And basically, after years of study of this particular problem, Nipah virus infections among case contacts were not generally healthcare individuals that probably take a little more precautions in terms of becoming infected and stay away from bodily fluids, but that's Nipah virus. So asymptomatic and mild Nipah virus infection seems to be rare, but symptomatic infections with Nipah virus doesn't seem to be the primary healthcare problem in Bangladesh, at least according to my interpretation. The next topic in the New England Journal involves progesterone during pregnancy. And you may recall this, but in the first trimester, there's a marked increase in human chorionic gonadotropins, and estrogen is excreted in increased amounts up till the time of delivery, and so is progesterone. And most of this progesterone in midst of the first, second, and third trimester actually comes from the placenta. And there's evidence to support that if there is insufficient progesterone present in early pregnancy, that miscarriage would occur to a greater degree. Now, this idea has been around since the 1950s, and progesterone preparations have been given to avoid miscarriage since I was in medical school, which was over 50 years ago. Now, we looked at a paper in the New England Journal in 2015, same investigators, where in women with recurrent miscarriages, vaginal suppositories laced with progesterone were applied during the first trimester in the hopes that this would avoid recurrence of miscarriage. And you'll recall that that study did not suggest that progesterone therapy during the first trimester would result in a significantly greater number of live births in women with a history of unexplained earlier miscarriages. This study is quite similar, same preparation, vaginal progesterone, and this therapy was applied to women that had spotting or bleeding during the first trimester, and the endpoint again was the number of live births. So there are large numbers of women in this study because bleeding in the first trimester is not that uncommon, and miscarriages occur in any event unrelated to progesterone because of maldevelopment and other problems. So there are 2,000 women, about 2,000 women in each of the two groups, and the randomization worked, and otherwise the women in the two groups are relatively similar. So they are all women that had spotting or bleeding during the first trimester. Half got progesterone suppositories and the other half did not. And what we see here is that the primary outcome and secondary outcomes were not affected by the treatment. And the only significant result, for reasons that I can't explain, is that women here, remember that the initiation into this study involves spotting during the first trimester, that had already had 3 or more miscarriages possibly benefited from the treatment. This result here is significant, but there are few women in this particular analysis, and otherwise the study was negative. So progesterone didn't seem to be better than placebo, and the investigators conclude that treatment with progesterone did not result in significant improvement in the incidence of live births in women with vaginal bleeding during the first trimester. Now, there's an editorial on this issue because since 1956, the Food and Drug Administration had approved hydroxyprogesterone caproate, marketed under the name of Delalutin, for multiple indications, including threatened abortion. And with this approval, the impetus for physicians to apply this therapy and enthusiasm was, of course, high. But analysis of data from the applications of Delalutin was not really consistent with the idea that this treatment was very helpful, and the results of the study that we've just looked at underscore that point of view. The next topic involves P2Y12 receptor inhibitors that are given to inhibit platelet aggregation. And this particular receptor that's involved here is a G protein coupled receptor, and under normal circumstances it's occupied by ADP, which results in platelet aggregation and an increased propensity to develop thrombi. It's a protective mechanisms, and there are various half a dozen ways in which platelets can be activated, and this is only one of them. Now, there are currently 3 agents on the market to block platelet aggregation in patients that need to have their platelets calmed down, like those that have coronary heart disease, etc., or those that have had an intervention involving stent placement. And those are clopidogrel, prasugrel, and ticagrelor. And ticagrelor is potentially reversible, whereas the binding of clopidogrel and prasugrel to the P2Y12 receptor is irreversible. Now, the issue is important because if patients receiving these agents suddenly develop intracranial hemorrhage or have to be operated upon, we'd like their platelets to exhibit normal function as quickly as possible. And with aspirin or with clopidogrel or prasugrel, we would have to wait for 7 days until the platelet complement has been restored by normal platelet production. And it might be helpful to have an agent that could reverse at least ticagrelor if your patients are receiving that particular drug. So investigators and industry are interested in developing an inhibitor for ticagrelor, which is the only one of these agents that's potentially reversible. So this paper in the New England Journal involved the use of an antibody against a component of ticagrelor to reverse the effects of that agent. And it was given to normal volunteers. So these are not patients and certainly not individuals that are bleeding. These are normal volunteers that are paid for their services. And there's a number of different cohorts in this study. So one of the questions here was, are there adverse events with this particular treatment? And then the second question here is, does this antibody indeed reverse the effects of ticagrelor? So there are several cohorts of normal volunteers that were recruited for this study. So the first thing that we can look at in any of the cohorts that were studied here, were there adverse events? And one patient got alcohol poisoning and aspirated and developed aspiration pneumonia. But actually, we don't think that this is a side effect of the antibody. This patient probably got his $1,000 and decided that he would have a pleasant evening and developed alcohol poisoning and aspiration pneumonia. Otherwise, the antibody seems to be well tolerated and couldn't really be made responsible for any of the adverse events that are shown on this table. Now, the cohorts here are a bit confusing and we can't go into all of the details. Some of the cohorts got to ticagrelor, others didn't, but in the later portion of the study, 3 cohorts received ticagrelor, and the patients that received ticagrelor received the last dose 2 hours before this antibody was given. So if we just look initially, if the patients got ticagrelor, platelet aggregation was restored to normal for a short period of time, and then the effects gradually wore off, and the effects of the drug did also. And in the cohorts 7 through 10 that all got ticagrelor, we see that platelet aggregation was reversed by the antibody over an extended period of time. So if we look at some other tests, platelet activity can be studied by light transmission aggregometry, whether or not the platelets aggregate. It can be studied by a platelet reactivity test. And to my interest, platelets also have vasodilator stimulated phosphoprotein, and we can look at the effects of the reversal of ticagrelor on that particular variable. So what we see here is that ticagrelor inhibits vasodilator stimulated phosphoprotein aggregation, and as soon as the antibody is given, this activity is restored to normal for an extended period of time. And the same is true for the platelet reactivity test, and the aggregometry is also restored to normal by the antibody. So we can conclude that this antibody looks indeed like it reverses the effects of ticagrelor, and we'll have to await studies in patients that are actually bleeding to see what the clinical ramifications of this effect are. Now, I also looked up to see how much ticagrelor costs, at least in Germany, compared to clopidogrel. And a year's therapy of ticagrelor costs €1,000, and a year's worth of clopidogrel costs €32. And I also looked for how much AstraZeneca is charging for this drug in the United States, and it seems to be about twice as much as the cost in Europe. So if all the cardiologists, instead of using clopidogrel, treat their patients with ticagrelor, we can expect that healthcare costs will rise accordingly. The next topic at the New England Journal is fairly complicated. It involves the effects of a group of microRNAs. Now, microRNAs are small segments of RNA that we make to reverse mRNAs made for other reasons. So this is a small regulatory element. And microRNAs are also encoded by genes that otherwise don't encode for protein, or segments that don't in any event. And these microRNAs are constructed in terms of a fairly large precursor that involves this hairpin structure here. And then the hairpin is cleaved by certain enzymes called drosha and pasha, and then these segments are cleaved in terms to make the actual microRNA by another enzyme called dicer, and then this small piece, miRNA, is incorporated into a complex called the RISC complex that is then responsible for stopping the effects of the target mRNA. So this is fairly complicated. Now, since there are a number of enzymes here, you might imagine that some of these enzymes might not work properly, and that might cause disease. Now, the word dicer was coined by the biologists that discovered this enzyme, and dicing is a cooking process where vegetables or whatever you have are cut into small cubes. And this biologist thought that the effect of this enzyme reminded her of, she probably had experience in the kitchen, of dicing. So at any rate, the pre-mRNA is worked on by drosha and pasha, and then made into a microRNA, and then that's cleaved by dicer to make this RISC complex that then works on the target mRNA so that the target mRNA is degraded. Now, there's also a syndrome that's involved with mutations in dicer1. There are various forms of dicers, and the dicer1 syndrome is known, and it results in the development of tumors in children, and the type of tumors are variable, and they're also a function of how old the children are. So this dicer1 syndrome has been known. So what this paper about is, in the New England Journal, is two children that have mesenchymal hamartomas of the liver. And these mesenchymal hamartomas of the liver have also been described, and you can see them, huge cystic lesion here in this liver, a slightly smaller one in this other child. And these things are known, and they are generally caused by mutations in a segment on chromosome 19 called the microRNA cluster, C19MC. But C19MC was sequenced by these investigators, and they found no mutations. But instead, what they found in one child, and also another child and his mother, were mutations in dicer. And the dicer1 syndrome is not really known to be responsible for mesenchymal hamartomas. So that's what this paper is about. So this is an example of mesenchymal hamartomas caused by mutations in dicer. And only one copy of dicer is mutated here, and the dicer1 syndrome is generally an autosomal dominant disease, implying either loss of heterozygosity or some effect on the mutation in dicer1 on one allele that interferes with the function of the other allele to cause loss of heterozygosity. So we look at these two children, and they both have a germline mutation in dicer. And then they have somatic alterations in these hepatic lesions. And if we look at the function of their dicers, in wild-type dicer, we see the products of the enzyme. That's all down here. And in these kids that have these mutations, in the first child, we see that some of these products aren't cleaved properly. And that was also the case in the second child. And these are the effects of the dicer activity in terms of their microRNA results are compared to normal individuals or individuals that have this MHL syndrome based on mutations in this microRNA complex on chromosome 19. And then a SNP analysis was done verifying that on chromosome 19q13 there were no copy number alterations, and some other molecular biology was done, and some interphase fish assays were done to corroborate all these results. And basically the bottom line here is that these hepatic cysts and these two children were caused by germline mutations in dicer1. The review in the New England Journal involves Well, it actually involves chronic kidney disease of unknown cause in agricultural communities. That reminded me of a chronic kidney disease which we now know what causes it, but it was also something that occurred in obscure agricultural communities, and that disease is Balkan nephropathy, which was described in Croatia and in Bosnia-Herzegovina and in some portions of Romania and Bulgaria in these isolated valleys. And this disease has been known for a fairly long period of time. Nobody knew what caused it. The people that got this disease not only got chronic interstitial nephritis, they were also subject to urogenital tumors. And eventually, after 60 years of effort, the cause was found, and that grain from these fields that these people used in making their bread had been adulterated by a weed that produced aristolochic acid. And aristolochic acid interferes with the nucleotide pairing that was at least responsible for the tumors. Exactly how the chronic interstitial nephritis comes about, I really don't know. But at any rate, in this paper in the New England Journal, we look at similar kinds of problems in other areas of the world. In terms of the renal biopsy, they are quite reminiscent of Balkan nephropathy, although as far as I know, these three conditions listed here don't result in urogenital tumors. And they are Mesoamerican nephropathy that occurs in Central America and people that are involved in sugarcane harvest, Sri Lankan nephropathy, which obviously occurs in Sri Lanka, also persons working in rice paddies, and another form of nephropathy that occurs in India. And histologically, these diseases look fairly similar, and since they all occur in agricultural communities, as did Balkan nephropathy, some sort of toxic effect is presumably responsible. Also on the list is glyphosate, which is this herbicide that's in the news because of huge settlement. Well, it hasn't been settled yet, but huge trials involving billions of dollars against the poor Bayer company that was stupid enough to buy Monsanto. But at any rate, so these are these three forms of kidney disease, and a whole bunch of things have been looked at that could possibly be responsible. And they're all listed on this table here, but I didn't think any of the arguments were particularly convincing. At any rate, toxic pesticides, heavy metals, etc., heat exposure, infectious agents could all result in possibly in Mesoamerican nephropathy, which in terms of histology looks like interstitial nephritis, reminded me of Balkan nephropathy. At any rate, from last week, here's the poor woman that has this choroid melanoma in her eye and beyond the eye. She had been blind 2 years earlier, but even in this description, we aren't exactly told why. But she had metastatic liver disease and died from metastases 2 months after presentation. Another image in the New England Journal, and indeed this is a very, very impressive abdominal aortic aneurysm. And we learned to our surprise that this patient still had femoral pulses. And this CT image here is remarkable. Here's this huge aneurysm. And he presented with abdominal bloating and constipation. He didn't even complain of pain, so he didn't even get any oxycodone. But at any rate, here's the aneurysm. Surgeons did a nice job on fixing his aorta with a Y graft, and he left the hospital and felt well. Now, the patient in the New England Journal is this 44-year-old man who gets a defibrillator placed below his left clavicle because of coronary artery disease and complications related to heart failure. So here it is. And then weeks later, he develops this lump that's actually above the clavicle. So the conclusions that the clinicians reached, and I understand why they would conclude that, is that this lump must have something to do with this defibrillator. So the patient undergoes a bunch of imaging studies, but this lump is not really vascular. There's no evidence of fistula formation. So the clinicians stick a needle into this stuff and find this brown fluid and send it off for culture, but it's sterile. And they treat him with cephalexin with the presumption that this could possibly be an infection that's somehow related to this defibrillator. And it doesn't go away. And he has pain, so he gets gabapentin, which I believe was developed for seizure treatment, but marketing has turned it into a pain medicine, and oxycodone to be taken as needed. So then he goes home, and he's a little better, but then it comes back, and the same thing happens again, and it's again aspirated and reveals this brown fluid, so he gets more cephalexin and more gabapentin. Now, when he comes in for about the third time, somebody starts getting concerned about all of this and takes a history, and he's got sciatica and heart pain, heartburn, and coronary artery disease. And in this obscure sentence that I found in this text, I had to read this twice. When this patient was 20 years of age, he had a testicular cancer for which he received orchiectomy and chemotherapy at another hospital. That's nice to know. He also gets aspirin, clopidogrel, simvastatin, carvedilol, lisinopril, more gabapentin, quetiapine, and omeprazole. He manages to avoid heparin because he has thrombocytopenia, and he helps himself also to cocaine, apparently, periodically, as if all these drugs weren't enough. So with this history and with this physical examination, finally, this thing is biopsied, and it shows the histology shown here, and it's got aspects of smooth muscle differentiation and also respiratory epithelium. So this is a tumor that has more than one cell type, surely, and also stains for cytokeratin and other markers. So finally, he gets this thing removed. And basically what this is, it's a metastasis from this testicular cancer that he had 20 years ago that was treated with platinum and other chemotherapeutic agents. And this is a metastatic teratoma and had nothing to do with this defibrillator. So we'll now move to the Lancet. And the first paper in the Lancet involves endothelin. And endothelin was discovered about 35 years ago. It's produced by endothelial cells, and it produces the strongest vasoconstrictor known. And endothelin binds to either the ETA or ETB receptor. These are G protein coupled receptors that that result in vascular smooth muscle cell contraction, but actually they have effects throughout the body, as shown in this little diagram here, and including the central nervous system. Now, our friends in the pharmaceutical industry have been very busy developing endothelial receptor blockers, and they're listed here, and they've failed for practically everything. Bosentan is on the market for children with pulmonary hypertension as an orphan drug, but otherwise, none of these other endothelin antagonists have ever been able to find a home, which is frustrating to many. Now, in this Lancet paper, we learn about atrasentan, and atrasentan is an endothelin antagonist, which was tried in this study to see if it would inhibit the development of diabetes-induced chronic renal disease. And because endothelin antagonists have such a mixed track record in these patients, they indeed seem to result in a decrease in proteinuria in some patients, but an increase in sodium retention and heart failure in other patients. What was done here is patients were recruited, they were all given atrasentan, and one looked for patients that had a decrease in their proteinuria. These patients were labeled as responders. And then the responders in this study were randomized to treatment with the endothelin antagonist or to placebo. We used to call this cherry picking, and that was what was done in this study. So they recruited 11,000 diabetics with proteinuria worldwide. And finally, when we get down to here, we see that there were 1,000 people that didn't respond to the treatment at all. They had no reduction in proteinuria, so they didn't bother with these patients. They randomized the responders. So these are the responders, and finally, of 2,600 people that were randomized, we've got about 1,000 left in this arm and 1,000 left in the placebo arm. So we see that they're type 2 diabetics, and they have glycated hemoglobin levels that are elevated, and they get a whole bunch of most of them are getting insulin. Very few of them get modern drugs that we would today give patients with type 2 diabetes. So what we see here is the responders, and they indeed had a decrease in albumin excretion. And then these are the guys that got placebo, and these are the guys that are continued with the endothelin antagonist for a period of 42 months. And what we see here is that there's an increase in brain natriuretic peptide, which is a marker for heart failure, in the patients that are treated, and the patients that get placebo also increase, perhaps somewhat less so. Now, these differences are not great, and I don't think they're statistically significant. There's also a slight 2 millimeter mercury difference in blood pressure that then disappears after 12 months or so, and body weight stays about the same. So if we look, the authors claimed that the composite renal outcome, which was a doubling of creatinine or ending up on dialysis, was less in the endothelin antagonist group than it was in the placebo group. That indeed seems to be the case. But if we look at these differences, they don't knock my socks off in this cherry picking study. And you'll have to draw your own conclusions, but I think that these differences are very slight, to say the least. And what I also don't like is that fluid retention was more common in the endothelin antagonist group, as were heart failure and the development of anemia. So I think the results of this randomized control trial, I'm surprised the Lancet published this study. The next paper involves patients that have cancer in the lower third of the esophagus. And this disease doesn't have a very good prognosis. Now, these are patients that have not yet had metastases and are subject to operation. And they receive perioperative chemotherapy. And one group got chemotherapy that's based on fluorouracil administration. That's the FLOT experimental group. And the other group got another chemotherapy combination that consisted of capecitabine, and they also got some fluorouracil here, and they received epirubicin. And these two chemotherapeutic regimens were compared. So the patients in both groups are seen similar, and their severity of disease is also similar, and the group that got the FLOT therapy had a slightly improved overall survival compared to the people that got the other chemotherapeutic regimen. And that was statistically significant and seemed to be the same or similar in all these various subgroups that are looked at. And of course, there are side effects from both of these forms of chemotherapy in these patients with this severe malignant disease. Now, this next paper is casually interesting. It's a part of the Global Burden of Disease study that's funded by Bill and Melinda Gates. And here the issue is the health-related effects of diet in 195 different countries throughout the world. And Is your diet low in vegetables? Is it low in whole grains? Is it low in milk? And is it high in red meat? And is it high in processed meat and sugar and salt and omega-3 whatevers? So here are all the countries on the planet. The rich ones are the red ones. And I think the hashed line is what oh gosh, I've forgotten. Is the global intake that was measured in 2017, and the drawn green line is what the pundits believe would be the optimal level of intake. And basically, what impressed me is that there are differences amongst these countries, but basically, I was surprised how they actually. Ich habe keine Ahnung, warum deswegen das machen. Ja. Der geht aber nicht weg. Ach, dies ist so ein Ärgernis mit diesen schrecklichen Dingern. Escape. Okay. Now I'm wretched thing. Ja, ich weiß es auch nicht. Nein. Warum gibt es mir jetzt nicht PowerPoint Presentation dieses Ding? Das wieder. Okay. So at any rate. So the countries are all about the same. So these are the disability adjusted life years. The red areas are doing worse than the green areas, and the blue areas are doing the best. And so basically diets low in whole grains and high in sodium seems to be a big issue here, and etc. And so if you're interested in this kind of material, you can look at this study in detail on your own. The next paper in the Lancet involves the risks of cesarean section, not throughout the world, only in so-called low-income and middle-income countries. We're not allowed to call them poor anymore. And there, the risk of C-sections is about 7.6 mortalities within 1,000 procedures. And that's so basically, this is a literature review on papers that have been published on this particular issue. And some of the papers are good and some of them are not so good, depending upon in terms of reporting outcomes and sample selections and overall qualities, and whether or not how many deaths were actually accounted for was variable in these publications. But basically, the results are indicative that if you're in sub-Saharan Africa, your chances of having a problem with cesarean section are greater than in other parts of the world. And a large portion of the world either isn't poor or wasn't reported in this particular study. So what we also might imagine is that the elective C-sections are of a lower risk than emergency C-sections. And what also, in terms of whether or not the elective C-section is performed in the first stage of labor or the C-section is performed later in labor, also has an effect on outcome. And if your section is done by the house staff, you have a worse result than if your C-section is done by an experienced physician. The review in the Lancet concerns medical care in Iran, which is the second largest country in the Middle East with a population of 80 million, fairly high population density. The authors are for the most part Iranian, so I assume that this publication has been approved by the government, and it involves various issues. But basically, Iran has the same problems as other countries throughout the world. They've got infectious disease pretty much hands-on, and now they're dealing with an aging population and non-communicable disease in terms of mortality. They have a great role model in Avicenna, who was a Persian physician who lived between 980 and 1037. He was a polymath, a physicist, a philosopher, and he also, incidentally, was the first to describe diabetes mellitus. Now, Iran is making some inroads in also educating women, and the number of women that are going to university has increased substantially since the year 2000, and they have reason to be proud of that. They have a rich and variable history in the last several hundred years. One notable point was in 1953, when their elected head of state, Mossadegh, was replaced by the Shah, a coup that was funded by the CIA and the British Secret Service. Whether or not that contributes to the fact that Iran is a theocracy and not really democratic in terms that we would define today, I'm not certain. The Iranians claim that their fertility rate is going down so that their population should stabilize, at least compared to the rest of the Middle East and North Africa. Public health has increased substantially in leprosy, tuberculosis, plague, parasitological diseases, and the rest of scourges of this nature seem to be, at least at the present time, pretty much in hand. Life expectancy at birth is plotted here. These dips here for males and this increased adult mortality occurred during the war that was largely sponsored by the United States, involving Iraq and Iran, that occurred in the 1980s till about 1988. But in the meantime, the population number is increasing unabated. And if we look at their current healthcare problems, since alcohol ingestion is a crime, that doesn't seem to be an issue. Cigarette smoking has stayed fairly constant, and the rest of their case mortalities improvements between 1990, 2016, and what's projected for 2030, or what they hope will occur, is listed here. We're almost at the end. I wanted to show you a paper on oxalate. Now, this is the structure of oxalate. Most renal kidney stones are calcium oxalate stones, and oxalate is present in the diet in a whole variety of things that are otherwise considered to be healthy, including spinach and nuts and things of this nature. It's metabolized poorly once it gets to that stage, and there are primary causes of oxaluria that involve certain genetic mutations, but otherwise increased oxalate excretion involves the ingestion of rhubarb and spinach, and it's higher in hyperparathyroidism and Cushing's disease, etc. Now, in this paper in JMA, the investigators looked at urinary oxalate excretion as a risk factor for the progression of chronic renal disease. And this is a very large epidemiological study involving thousands of patients with a risk for progression of chronic renal disease. This is the so-called CRIC study. And these patients were divided into quintiles in terms of their oxalate excretion. And you can see these quintiles here. So this is urinary oxalate excretion milligrams per 24 hours, and we see increases across the quintiles. And we can also see some effects in the quintiles in terms of hypertension and diabetes and these things that we would expect. Also, perhaps some medication ingestion associations, some of which I understand and some of which I don't. Actually, oxalate excretion should be relatively independent of the level of renal function. Here are factors that are associated with 24-hour urinary oxalate excretion. It's inversely associated with urinary calcium excretion, which I think is interesting because you might imagine that if we increase calcium intake in the diet, we would bind more oxalate in the gut, and there would be less that would be necessary to be excreted in the urine. If we look at ESRD, we see a substantial association across the quintiles, end-stage renal disease, in terms of increased oxalate excretion. So the quintile 5 does quite a bit more poorly than quintile 1, implying that perhaps the necessity to excrete large amounts of oxalate might increase the propensity to develop chronic renal disease, and might perhaps also allow some avenue of intervention that could be done. So basically, higher urinary oxalate predisposes patients to kidney failure in this study. And oxalate is not trivial to measure, so I outlined how oxalate was measured in this study. And we're going to stop here. This is a 58-year-old man who's in an intensive care unit. He'd been on a ventilator for 31 days. He gets extubated and suddenly has to be intubated again. And here's his electrocardiogram. He's going along okay, and then he develops this, and then he develops this and this. And the question, it looks like ventricular tachycardia degenerating to a ventricular flutter. But if we look at these waves in more detail, particularly this one here, we can see that this is a QRS complex, and then there's this tented T wave. So this could possibly be hyperkalemia, but this would be a very, very abrupt, sudden hyperkalemia. And that's more than you get from eating 2 bananas. And so the question is, how could this come about? So the question in the Lancet is this acute coronary syndrome? Yes, maybe it could be. Is this an anaphylactic reaction? I wouldn't think so. Is this malignant hyperthermia? Not occurring in seconds, but what this could be is succinylcholine-induced hyperkalemia, where the administration of this muscle relaxant results in depolarization of all end plates in the body that then cannot repolarize. That's how it paralyzes the patients. Succinylcholine results in acute potassium release, and this potassium release could be responsible for this sudden hyperkalemia. And this side effect from succinylcholine is known, and it's particularly likely to occur in patients that have been immobilized or confined to bed for long periods of time because their end plates are particularly, their acetylcholine receptors are particularly prone to the development of this complication. So this patient had hyperkalemia associated with succinylcholine. That's it in English. Thank you very much.
Hast du noch gerade eine Minute?
Ja, ich kann